Hello again, and this time I'm going to go ahead and talk about anemia. But before I get into that, I want to mention briefly on the dysphagia talk or the trouble swallowing. There's a point of confusion, and the point of confusion has to do with what x-rays to look at when it comes to dysphagia or trouble swallowing. So it's important to realize that there's two ways basically of looking at this. One way is called a barium swallow, which I previously mentioned, where it focuses on the esophagus all the way down to the stomach. And then you have what's known as a modified barium swallow, which is usually carried out by speech pathology. And I think a lot of people aren't aware of that. And the focus is really up in the neck and having to do with transfer dysphagia or trouble with coordination between the voluntary muscles swallowing and the esophagus, which is involuntary muscle or smooth muscle, as opposed to skeletal muscle, which is voluntary. And mostly for people who are having trouble swallowing with motility problems or trouble with aspiration, perhaps after a stroke, which is the more common situation. Sometimes people need to have both examinations done. Those are x-ray examinations. Now we're going to talk about anemia. So anemia is where the red blood cell count is low. It is not related to platelets. It is not related to white blood cells, but the red blood cells. And the red blood cells then, we're talking about hemoglobin and hematocrit. So in gastroenterology, we get a lot of referrals for anemia with the question of, is the patient losing blood from the GI tract? And is there a cause for it, such as colon cancer in particular? So a lot of patients then would get referred to gastroenterology for anemia. Now, this is an area that requires some blood work to look into further. And a lot of times there's confusion here. First of all, a lot of patients are sent for colon cancer screening. Some of them have anemia, and if you have anemia, you may be losing blood from the colon or perhaps somewhere else, or something else is going on. And unfortunately, in gastroenterology, there's been so much focus on colonoscopy that there's been a situation where people, and I'm talking about doctors in primary care or the referring doctors, will look at the blood count and say, well, this patient has anemia, they need a colonoscopy, I'm going to send them for a colonoscopy or colon screening. And colon screening is like 2 words as opposed to anemia, which is 1 word, but it really, I think, is typical that a patient who has a low blood count might just be sent for a colonoscopy. Well, the gastroenterologist should not really be just a technician. They should be also a doctor. So in our practice, we wanted, at least I wanted to see if they were sent for anemia. So if they had recent blood work, I wanted to see what the results were, because that's important. Because you're not just looking in the colon when you sedate the patient. You need to look in the stomach as well, because people can have stomach cancer or chronic ulcers or other reasons for their anemia. And when you have anemia from chronic blood loss, you usually have iron deficiency anemia. So it's important to see, is it iron deficiency anemia? And if you have iron deficiency anemia, some patients will have associated B12 deficiency as well. So you want to make sure you check the boxes. Does the patient have B12 deficiency? Is it just iron deficiency? Is it both? Is it neither? Is there a folate deficiency? What is going on with the blood count? It may be that the patient needs a colonoscopy, but they may need an upper endoscopy as well. And usually I would do that at the time of colonoscopy. Also, when you do an upper endoscopy, you can obtain small biopsies through the working channel of the scope to look at the small intestinal lining to see if there's any evidence of celiac sprue, which can cause iron deficiency anemia. And of course, there are some patients that have iron deficiency anemia that simply donate a lot of blood, and perhaps that's why they have that. So it's a complicated issue. Now, looking at the stool for blood may or may not be helpful because, yes, people can be positive and show blood in the stool, but they can also bleed intermittently and may be negative at the time that you checked their stool for blood. So it's a complex issue, not a simple issue, and there's a tendency in medicine and in life to simplify and oversimplify issues for convenience sake, or get on with the work, or move things along, or for reimbursement issues, a number of reasons why. So that is commonly the situation there. In terms of tools that we have to evaluate anemia, from a gastroenterologist standpoint, you can, and if you think that it's iron deficiency anemia and the patient is losing blood in the GI tract, you can perform upper endoscopy, you can perform colonoscopy, you can also do what's known as capsule endoscopy, where the patient swallows a capsule that takes pictures throughout the small intestine to try to cover the area in between the upper scope and the lower scope. Now, there can be problems with that, and capsule may pass an area that it misses, an area of importance, or it could be that it sees something, but you can't keep it in one position very long to know what that is, or it could be that the battery runs out before it gets all the way through the colon, or it could be it's stuck in the stomach, the patient has gastroparesis. So there can be a number of issues. There are small intestinal scopes that can go all the way through the small intestine. Commonly, they don't make it all the way through because of looping and other issues. And so it may be that you have to approach the patient through the mouth and get as far as you can, and then go from the colon and get into the small intestine and go in that direction. Sometimes the patient has to have a scope kind of telescoped through the small intestine at the time of an operation in the operating room. So there's a number of ways of looking at the small intestinal tract. There are certainly patients who may have heavy periods. There's some women that may have heavy periods that causes iron deficiency anemia, and it may be that they have endometrial cancer or some other reason for that. And so it may be important to do CAT scans of the abdomen or send the patient to GYN for evaluation there, but certainly want to inquire about their periods and heavy periods and such. So there can be a number of reasons, and it can be more involved than one might think. Now, in the book and the chapter, I present some cases that are pretty strange and wild, things that I've encountered through the years. And one of the strangest, saddest cases was a patient who was swallowing nails, and this patient had some psychiatric problems, but it became an issue while he was in the hospital, certainly. And if you want to read more about that, that's in the book. Also, it should be noted that pica is a common symptom for iron deficiency anemia. That symptom is chewing ice. So there are patients who are chewing ice out there. Some of them are ruining their teeth, going to the dentist, having a lot of dental work done, and the real cause is iron deficiency anemia. This can be a spectrum. Some patients with iron deficiency don't have pica or ice craving. Some patients will go to special restaurants to obtain bags of ice, and the Sonic in particular came to mind. Or certain restaurants, they love their ice and they'll pick up a bag of ice. It can turn into almost a religion with them. They really enjoy chewing the ice. Some patients will even buy ice machines. So there's a whole spectrum out there. I talked to one patient and asked her about whether she was, as we progressed through the history, going to the Sonic and getting bags of ice, and she asked if I was following her. So this is a common problem. And in my experience, when the iron deficiency is corrected, the pica or ice chewing tends to resolve. Now, there's another problem that happens. There are some patients that go to primary care, they're diagnosed with iron deficiency anemia and put on iron, but never evaluated for why did they have iron deficiency in the first place. And I always think that it's like a patient has seizure from a brain tumor, but you never get a CAT scan of the head and you never know why they had that. You just put them on seizure medication. So it's important to figure out why the patient has iron deficiency, not just treat their iron deficiency. And generally, you have to take medication 2 or 3 times a day. The iron pills, they may not be well tolerated. They're taken with food. A lot of patients quit taking them early. So the blood count has to be followed, and keep following it. Even after the iron deficiency anemia is resolved, you want to make sure that it stays resolved. And I can remember patients I've seen where we treated their iron deficiency, found the cause, and then later they are sent back for iron deficiency again. Well, and they never took all their iron and they never repleted their iron stores. It takes 6 months or more to replete your iron stores. And that's if you stop losing blood. So it's important to recognize that. And if the patient has B12 deficiency, you want to treat their B12 deficiency as well and try to figure out why. Some patients have pancreatic insufficiency. It may be from that or other causes. And there are some patients who don't absorb iron, don't absorb oral B12, and you have to give injections or intranasal or sublingual B12. So all those issues really have to be considered. I think at this point in time, I will also mention that there are patients that do not have B12 deficiency, do not have iron deficiency or other obvious cause, who have anemia because their bone marrow is not producing iron. Not producing enough red blood cells. And they may have trouble with their white cells. They may have trouble with their platelet count. They may need to see a hematologist. They may need to have their bone marrow evaluated to see why they are not producing red blood cells. So it is not a simple issue. And with that, I think I'll go ahead and pause here.